Assalamu alaikum. Today we will talk about one of the most common congenital heart disease, and yet one of the most difficult one. It's the VSD. So we will go, this is part 2. Hatem went through the part 1, but this is part 2. So VSD is the most common congenital heart disease. Actually, this is the most common congenital heart disease that the adult or pediatric cardiologist will ever see. 50% of the children with congenital heart disease have a VSD. So VSD might be a component from other congenital heart disease. And 20% of the patient will have an isolated VSD. Bottom line, anyone who works with congenital heart disease will see a VSD. VSD could be diagnosed clinically. So actually, you will hear a loud, harsh, hollow systolic because the shunt depends on the pressure gradient difference between the LV and the RV, and you will hear it on the lower left sternal borders. I put here a link for the how to listen to this harsh systolic. Okay. If you'd like to go for a diagnosis of VSD by echo, this is bedside imaging modality, so it will be and it will remain the first imaging tool for any cardiologist. So you have to have a checklist in your mind. This checklist that you have to give an anatomical detailed evaluation of the VSD, and you have to give a hemodynamic evaluation of the VSD. Is that clear? So our echo reports will have two components, the anatomical component and the hemodynamic component. The anatomical components is 4 points. In these 4 points, you have to define the exact location of the VSD, the type of the VSD, and the relation of this VSD with the valves and the valve attachment that related to this VSD, identification of complicating factor or actually the sequelae of having this VSD. It depends mainly on the type of the VSD, and description of the size, as we mentioned, briefly described before the lecture, and we will have a question mark about the size. And be careful that I put the size in the anatomy, not in the hemodynamic. So this is the 4 points we have to check in the anatomy. And the hemodynamic, it depends on the magnitude of the shunt, and the sequelae of having this magnitude of shunt is left to right shunt, so the lung will be overflooded. As a consequences, the right ventricular systolic pressure will be increased. So we have to mention something about how to estimate the right ventricular systolic pressure and magnitude of the shunt that we have left to right shunt. So in normal, that pulmonary flow will be equal to the aortic flow, but if you have left to right shunt, the pulmonary flow will be increased by the magnitude of this shunt. So we use the terminology of pulmonary flow to systemic flow, or QP, the pulmonary flow, to the QS, the systemic flow. So any reports should have this 6 points, 4 points about the anatomy and 2 points about the hemodynamic effect. Okay. The VSD, there is source for having these difficulties in identifying the type of the VSD. Actually, the nomenclature of VSD, we have Van Braak, we have Anderson, and we have others. Look for that. I will give one example. So if Van Braak call it conoventricular VSD, Anderson call it premembranous outlet VSD, the other call it subaortic infracrystal, and the paramembranous, and the Hegler call it membranous. Other example, Van Braak call it conal VSD, juxta-arterial, infundibular and subarterial and supracrystal. So actually, the nomenclature of VSD is a bit complicated because different. This was at autopsy time. So actually, they are morphologists. They are great morphologists. They describe what they see according to the anatomy, not to the clinical and the imaging scenario that we have. So actually, this is source of difficulties in the VSD, that we have different schools in the morphology and they use different names. What we use in reality, what Hatem said the last time. So actually, the type of VSD are 4 types of VSD. We will start by enumerating them. So we have muscular VSD, and this means that all the margin of this defect have a muscle. We have different types according to the site of the VSD, but in the bottom line, any VSD that all the edges are surrounded by the muscle, we call it muscular VSD. Okay. We have premembranous VSD that is bordered by the fibrous continuity between the aorta and tricuspid. So, is it clear? The premembranous VSD that is surrounded by the aorta and tricuspid as upper margin. And we have an subarterial VSD that is directly related to the semilunar valve, the aorta and pulmonary. And the last type is the LF VSD, which is very common in the canal in the atrioventricular septal defect, just beneath the tricuspid and mitral and surrounded by that. So for the clinical purpose and for the types of VSD, they are the 4 types that we have. Either we have muscular VSD, premembranous VSD, subarterial VSD, or inlet VSD. Is that clear? We will forget about the pneumoculture that all the schools do it, but we define the VSD by these 4 types. As I said, we depend mainly on the echo, so you shouldn't send the 4 cross imaging unless that you have a specific question for that. We have 4 views: long parasternal view, short axis view, we have apical 4 or 4-chamber view, and we have apical 5. In each type, we will mention which view will help us more and where we can see this type. In echo, we depend on the 2D and the color at the same time. We use both of them as alternative. Is it clear? We have 4 views: parasternal long, parasternal short axis, we have apical 4, and we have apical 5. We will start now with the first type of the VSD. Premembranous VSD is the most common type of the VSD. Almost 80% of the all VSDs is premembranous VSD. As we said, the upper border will be related to the aorta and the tricuspid. Okay, which view of this will not help us to see the VSD? We have to look for the aorta and we have to look for the tricuspid. Which one does not have the aorta and tricuspid? Apical 4. So apical 4 is not the view that you use it to look for the premembranous. Here in apical 5, so we have the tricuspid and we have the aorta. This is the location of the VSD. Here in the long axis, you will see something that the defect under the aorta. Defect under the aorta is not a type, but this is a location. Something is happening here, but does not mean that this is premembranous. It could be premembranous, it could be other things. Here in short axis, you see it between the aorta and the tricuspid. Here is the defect. Is it clear where we can look for this VSD? Okay, by echo, this is the standstill images. Here, this is the aorta, and we find the defect here. This does not mean that this is premembranous. We have to confirm that this defect is between the aorta and the tricuspid. This is premembranous VSD. Is that clear? Okay, we're going to the loops now. Okay, so we have a VSD related to the aorta, but we have to confirm that this VSD is between aorta and the tricuspid, absent here. This is the VSD is bordered by the fibrous border for aorta and tricuspid. Is that clear? How to see the premembranous VSD? Okay. Premembranous VSD is one of the most common types of VSD that have a complicating factor. One of them, that the aortic cusp will be prolapsed in this VSD. So actually, it might close the VSD totally or leave a residual of this VSD. So we call it prolapsing of the aortic cusp. And because the geometry of the aortic valve will be changed, it might be associated with aortic regurg. So this is a damage of the aortic valve that's associated by the aortic incomplete. This is the cusp is prolapsed in the VSD, leaving a small defect, but leading to the degeneration in the aortic valve and have and aortic incompetence. It might be more severe. Here we have a lot of colors. So this is aortic incompetence during diastole. And this is a VSD during systole. But here we have a continuous color that's going into the RVUT, right? Again, this is during diastole. And this is during systole here. But here, from the aortic cusp, we have a continuous flow. What is this? I wrote it in the title. So it's rupture sinus of valve because of Venturi effect, because the pressure gradient is really high between the LV and the RV. So the prolapse of aorta could lead to the aortic incompetence and more severe to rupture one of the coronary cuspes inside that. So the prolapse of aorta by itself is not, I give it here an asterisk, because regardless the hemodynamic effect of this VSD, you remember from Hatem lectures that he said diagnosis of VSD is not an indication for intervention. We have to look for the hemodynamic significance. But this is one of the cases that regardless the hemodynamic effect of this VSD on the RV and on the pulmonary artery, having a prolapse of aortic cusp either with mild aortic incompetence, prolapse aortic cusp itself is not an indication for closure of this VSD, but keep an eye on that child because aortic valve will be damaged and we will have to do a major operation to repair this aortic valve. So it's much better to be safe than sorry. So this is one of the indications. If you have a prolapsed aortic cusp with even with mild aortic incompetence, you just push for the surgery, not because of the VSD, but because of the complicating factor. And of course, if you have a rupture sinus of Valsalva, this is also an indication to go for surgery, regardless the hemodynamic effect of this VSD. We send this patient because of the complicating factor. This is the first one. The second one, this is the VSD. Which type? We have here something. This is the VSD underneath the aorta, and when we did short axis, we find that this is the aorta and this is the tricuspid, and we have a VSD between the aorta and tricuspid, and we call it premembranous. Here the VSD between the aorta and what? Which structure is here? Pulmonary valve. We call this part of the septum conal septum. So now the conal septum is not attached to the tricuspid point. So we have a free conal septum. This conal septum could be malaligned, so deviated either anteriorly or posteriorly. So if deviated anteriorly like that, will produce RVT obstruction, which is fallow. So now this VSD become a part from other category. So regardless the hemodynamic effect of this VSD, now we are talking about other category, the tetralogy of Fallot, and now the indication of repair will be in this lesson of tetralogy of Fallot, not because of the hemodynamic effect of this VSD. So the anterior, the malalignment, we will have a category of tetralogy of Fallot. Okay, this is how it looks like. So this is the aorta, and this is the conal septum here. Conal septum is anteriorly deviated, produce RVT obstruction. This is very pathognomonic for the Fallot. And again here in short axis, we diagnosed premembranous VSD with anterior deviation of conal septum. Another asterisk, we does not look in this case for hemodynamic effect of this VSD. Okay? We look for the category of sometimes the obstruction is midway, so this is the septum, and actually here aorta, tricuspid, premembranous VSD, right? We have here the muscle band actually not related to the pulmonary, somewhere in the middle of the RV. So this is hypertrophied muscle band in midway of the RV. So this premembranous VSD is complicated by double chamber RV. So what is the difference between that and the previous one? The previous one is up to the RVUT. So actually, this is conal septum between the pulmonary and the aorta and the cerebellum. Sometimes this is a protective mechanism, that this is hypertrophied muscle. Anyway, if this muscle is obstructive like that, so we have a premembranous VSD complicating by double chamber RV, and again another asterisk, regardless the hemodynamic of this VSD, we will send this patient for surgery due to the complicating factor of this V. Okay, so this is the anterior malalignment and the double chamber, aleph, beta, low in the level of the RV in the middle of the cavity. This is aorta, a VSD. Okay, look for here for this septum. It's posterior deviation, anterior for the pulmonary, posterior for the aorta. So this posterior deviation usually associated with LVT obstruction. This is small aorta, and usually complicated with LVT obstruction and coarctation and whatever related to that. So posterior malalignment of the conal septum in premembranous VSD also a complicating factor. So now we have 4 complicating factors, either to have a prolapse of aorta and aortic incompetence and ruptured sinus of Valsalva, or no, I'm just enumerating the previous one, not that one. Anterior malalignment of the VSD, conal septum, double chamber RV, posterior malalignment. Okay, this is bedfold. Sometimes the tricuspid tissue we have here, aorta, and this is the VSD, and this is the tricuspid. We diagnose that as premembranous VSD. Sometimes the tricuspid tissues try to close this VSD. So actually it leaves small VSDs. So here this is LV underneath the aorta, going to the RV, going to the right atrium. First thing that we overdiagnose that this tricuspid regurg with high velocity, and we misdiagnose as elevated right ventricular systolic pressure. It's not. And another type to call it like Joubert defect. This is not Joubert defect. Joubert defect is very, very rare VSD. It's overdiagnosed when it comes like a case of this. This is premembranous VSD. So this is the defect between the left ventricle and right ventricle, and this tricuspid tissue is trying to close it. And we see some backflow from this small, minute bit folds in this tricuspid tissues. But Joubert defect is the defect between the left ventricle and the right atrium. This is the true Joubert defect, that we have here a defect in the membranous between the LV and the right atrium. This one is a defect between the LV and the RV, and the backflow is going to the tricuspid. So this is not to be mistaken with tricuspid regurg. Otherwise, you will have an falsely elevated right ventricular systolic pressure and not be diagnosed as Joubert defect. Okay, premembranous regarding the hemodynamic effect. If you have one of these complicating factor, we don't go for the hemodynamic, we just report that we have a complicating factor for this premembranous VSD, and we have to deal with this. Okay, is it clear about the premembranous? Okay, we will move to the subarterial VSD. It's not that common. It's up to 10% of the VSDs that you will see. It's more common in the Asian population, not in the African one. This defect is just underneath the post-millunar valve, the aorta and pulmonary, and this means that we will not have a conal defect, a conal VSD. So we don't have malalignment anterior or posterior. Conal septum does not exist. Okay, if you look for this picture, which one will not help us? Which two will not help us? Two views will not help us. It's about the aorta and pulmonary. So apical 4 will help us. Okay, and the apical 5 is underneath the aorta and pulmonary. So this VSD, we don't look at the apical 4 or apical 5. This is the VSD here. It's between the aorta and between the pulmonary, and we don't have this conal septum. It's opposite. You will see something underneath the aorta, like what we saw in the premembranous VSD, But when you do the short axis, you will find the communication is, this defect is guarded by the aorta and pulmonary. This is the images that we see. In parasternal long, you see a defect here underneath the aorta. It might be premembranous, it might be an subarterial. Here in the short axis, this is intact, so it's not premembranous VSD. The VSD is just between the aorta and the pulmonary. This is the VSD and this subarterial VSD. Okay, what is the complicating factor could be in this VSD? Cusp prolapse. It could be. It's less common than the premembranous VSD, but it could be prolapse in the cusps like here. So if it's complicating with aortic valve prolapse, we look carefully for the aortic incompetence. If there is any aortic incompetence, we will go to deal with this complicated. It's not that common. This VSD is up to 10% of the VSDs, so it's not common to see it in the clinical practice, but you know it if you saw it. Okay, the LVSD is located just beneath the AV valves, the tricuspid and mitral. Commonly, it can come as isolated LVSD. It's very unlikely to come as an isolated VSD, but in most to see it in the atrioventricular septal defect, the canal defect. But you can see LVSD as an LVSD. Okay, which view will not help us? Parasternal long will help us. It's something to look underneath the mitral and tricuspid. So this will not help us. In short axis, apical 5. Yes. We have the aorta here. So this is not inlet. So actually, the only one can help us is just an apical 4, and very easy to do that. This is an inlet VSD. So at the level of the mitral and tricuspid, we look for the inlet portion from this VSD. So this rim from the VSD is by the mitral and tricuspid. So this is an inlet VSD. It's very easy. Just the apical 4 and you will diagnose if you have an inlet VSD. Apical 5 is not for the inlet VSD because you went for the outlet. So parasternal long does not help. Short axis does not help. Apical 5 does not help. Okay. Another thing, you saw here in apical 4, the malalignment between the intraventricular septum and the intra-atrial septum. Yeah. If just draw an imaginary line from the intraventricular septum and the imaginary line from the intra-atrial septum, it will be not cross each other. And this produce what? Produce an overriding of one of them. Which valve from mitral or tricuspid is overrided the VSD? Tricuspid is overridden. Is it clear? Because of malalignment of the intra-atrial septum and intraventricular septum, this produce shifting, overriding of one of the annulus. It could be the mitral, it could be the tricuspid. So overriding, this means that annulus just shifted from its position due to the malalignment of that. Overriding by itself is not a problem. It's just a sequences of this inlet VSD. So the overriding, it means malalignment of the atrial and intra-atrial septum and the intraventricular septum produce some degree of overriding, and we can look it over. It's not really a problem. What we consider really a problem is straddling. Straddling is a feature of the subvalvular apparatus. So it could be tensor apparatus, chordae tendini, or Babinii muscle. So if one of them, either the subvalvular apparatus, either the Babinii muscle or the chordae tendini, cross from one ventricle to the other, we call it straddling, like if you riding a horse. So this means that this is straddling. Overriding is just for the annulus. Straddling, we are talking about the subvalvular apparatus. For example, this is an inlet VSD. Why this is an inlet VSD? Because this is the mitral and this is the tricuspid, and we have here a VSD. It's modified apical pole. Look for the tricuspid. Tricuspid is overriding this VSD. Exactly. And here, one of the subvalvular from the chordae tendineae is just inserted on the crest of the septum. So we have here some question about the straddling. Look for this one. Which straddled here? Subvalvular apparatus of the tricuspid. The papillary muscle of the tricuspid is inserted in the left ventricle, and this is the papillary muscle. Okay, is it clear now? This is mild degree, just an overriding with the subvalvular apparatus attached to the crest. Here we have a papillary muscle that crossed the ventricle. This is straddling tricuspid. Could the mitral straddle? Yes. This papillary muscle and chordae tendineae inserted in the right ventricle. This is really never diagnose an inlet VSD without commenting that there is no straddling or there is a straddling. Why? This is straddling prevent if the surgeon try to close this VSD because it's hemodynamic significant, so he will cut the papillary muscle and the chordae and distracted the EV valve to close the VSD, and this is not possible because it will end up that you have a leaking EV valve. So this is another point. Regardless the hemodynamics effect of this VSD, we should not close an inlet VSD if we have an straddling. We will see what we will do, but this is contraindicated to close a VSD that have a straddling EV valve. Okay. Another association with this inlet VSD, that the left EV valve will be clefted. What means that left EV valve will be clefted? That we will have a tear, we will have a hole in the left EV valve, and this, the mitral, we call it now the mitral, and we will have incompetence. This here, look for this standstill image. This is the posterior, this is the anterior, and this is the cleft. Here, this is sweeping up and down in this one. So you will find the mitral, this is the papillary muscle, this is the posterior, and this is the anterior clefted or injured, or there is a tear. If you have an inlet VSD in your report, you have to say that I don't have overriding, straddling, and what about the left EV valve? Is it clear? Okay. Okay, the muscular VSD is compromised actually up to 20% of our VSDs. They could be described according to the location. So anterior, mid-muscular, posterior, apical. This means that all the rims of VSD are by muscle. Okay. Which views can we use to diagnose the muscular? All the views. Here we have a VSD, this one, and it could be here, and it could be here. Another peculiar muscular VSD here in the short axis. If we have a muscle between the aorta and tricuspid, and we have a muscle between the aorta and pulmonary, but we have a defect in the middle, so this defect will be muscular because it's surrounded by all walls that there is a muscle. We call it outlet muscular. Again, in the short axis, we look carefully between the aorta and tricuspid. If you have a defect, we call it between the aorta and tricuspid premembranous. If you have a defect between the aorta and pulmonary, we call it subarterial. If we have muscle between the aorta and tricuspid, and we have the conal septum between the aorta and pulmonary, but we have a defect in between, we call it outlet muscular. Is it clear? So all the views can help us in the muscular VSDs. Is that clear? You can diagnose all of them, but this part a bit tricky. Sometimes you misdiagnose it as subarterial, sometimes you diagnose it as premembranous, but look carefully. If there is a muscle between the aorta and tricuspid and muscle between the aorta and pulmonary. So you are dealing with outlet VSD, but it's surrounded by muscles, so we call it muscular outlet. This is the only peculiar muscle in that. Okay. This is very easy to diagnose. Actually, this is parasternal lung. We have a defect here. This is the aorta. There is muscle underneath the aorta. It's not premembranous. It's not subarterial, but it's muscular VSD. In short axis, we have a muscular VSD. In the mid septum, we have a muscular VSD. So actually, the muscular VSDs, you can diagnose it by color here. Okay. Here in the septum, you have multiple VSDs. Okay. This is again, you sweep it here, so you find the VSD. What is the problem of this muscular VSDs? These muscular VSDs have a tendency to come together. So actually, if you find a VSD in the muscle, in the echo, you have to look carefully if you have other VSDs or not. So if we have multiple VSDs and they are large, so actually the pressure is equalized between the LV and the RV. You will find a state of equilibrium, that the color does not move. And because of hypertropicalization of the ventricle, it might be easy to miss this muscular VSD. So as I said, this muscular VSDs, each one of the previous VSDs, usually it's a single isolated VSD. So we have one premembranous, we have one subarterial, we have one inlet. But in the muscular VSD, because the VSD is a complex structure and a curvature structure, so it's very easy to miss another VSD. Okay. What we do in that, we look carefully. And if you have a problem, the first time I said, send this patient for another imaging modality. And the best imaging modality with the highest spatial resolution is the CT. And do the CT as gated CT. What does it mean, gated CT? Sometimes to reduce the radiation, we do it non-gated CT, and this can be useful in extracardiac structure that does not move, like aortic coarctation, if you have total anomalous pulmonary venous, any extracardiac. But if you're looking for the intracardiac, you have to ask for a gated ECG, for a gated CT. And this means that we will scan during the cardiac cycle. So we have systole and we have diastole. So, and we make it like phases. We can make it 100 phases, but usually we make it only 10 phases. So the first 50 phases in systole, and from 50 to the rest is diastole. So if you think about how to detect a muscular VSD, you would like to detect it systole or in diastole? Diastole. Why diastole? Diastole is the correct answer. Why diastole?
It intended to occlusion.
Yeah, because in systole they tend to creep over each other. They are collecting. So if you have a muscular VSD, small one, if the muscle contracted, you will miss it. But if in diastole, so usually look for the VSD in CT and diastole like this. Muscular VSD tend to come together. The other VSDs tend to be only sola VSD, but muscular VSD. Why we stress so much about this point? We stress it so much because when there are too many VSDs, they call it Swiss cheese. So it's like this one. So actually, the Swiss cheese is contraindicated to be closed because it will end up that you will enter the operation and you will find nothing to close because they are multiple. So if you find multiple VSD, it could be one indication that this patient will not close this VSD. Okay? So now, if we recap what we have done until now, we went through the anatomical points in the VSD. So we have to look for the exact location of the defect. We use 4 views: parasternal long, parasternal short, apical 4, and apical 5. This is the basic. You can use other views, but this is the basic. And you have to describe carefully the relation between the VSD and the other valves that relatedly. You have to, in your report, you have to include in your reports the positive finding and negative finding for complicating factors. So in case of premembranous VSD, I have to say what? If there is a prolapse, there is a prolapse, there is no prolapse of the aorta, aortic valve is competent, and we don't have any aortic incontinence. There is no obstruction in the RVOT, there is no mid-wall, mid-cavity obstruction in the LV, there is no posterior malalignment in that. So I have to recheck the checklist of complicating factors that can send this patient to surgery. And in the LVSD, what I have to report? Overriding, straddling, cleft in the left AV valve. And in subarterial VSD, what I have to report by positive negative? Prolapse of the aorta. And in the muscular, what I have to define? Screening of the intraventricular septum if there is other VSDs or not. Exactly. Now we will move to the next point about the size of the VSD. This is the last point in the anatomical point. Okay. The size of the VSD, it becomes historical. So actually we don't stress that much on the reporting for that, but it's just for completion of this report. In historical, we compare the size of the VSD to the size of the aorta. And it will end up that I have a small size VSD, moderate size VSD, and large size of the VSD. If the VSD defect is less than 1/3 of the aortic valve annulus, we call it small. If the defect is larger than half size of the aortic valve annulus, we call it large. If it's between 1/3 and 1/2, we call it moderate. And how to measure it? On the color image, we take the largest diameter that we have for the VSD. Okay, is it clear now? We compare the aortic valve annulus with the VSD. If it's less than 1/3, it's small. If it's more than 1/2, then the aortic valve annulus is large. If it's between 1/3 and 1/2, we call it moderate. Okay, so why we didn't say if you have a large VSD, so it's hemodynamic significant VSD. If you have a small VSD, so it's a hemodynamic insignificant VSD. I will answer that in the hemodynamic, but we have pitfalls for this measurements. First of all, that we use an echo. This is 2D imaging. So the pitfall, the defect might be not round, might be an oval, and you see one plane, but the other plane is not in your imaging. This defect may have an oblique course, that especially the muscular VSD, that it goes from the left ventricle to the right ventricle in an oblique way. So actually you measure the defect in one point during this journey. It might be the 3D echo imaging could help in that, but 3D echo is not in the daily practice. So actually, because of this pitfall, we intended to ignore the size as mark for the VSD, and we measure the size but also the hemodynamic description of the VSD. That's why we mention the size, but actually we say it's something like 4x5, but we have to describe the VSD if hemodynamic significant or in hemodynamic significant. Otherwise it will be very easy. If you have a large VSD, it's hemodynamic significant. If you have small one, it's hemodynamic significant, but not in the clinical practice. Is that clear about this point? Historically, but nobody uses it currently. If you just measure the VSD in the maximum diameter and you put it in the report, but not this enough, you have to report the size and the next the hemodynamic. Is it clear now? Any question about this? Okay, to recap again, the 4 point about the anatomy is the exact size of the VSD, the relation of the VSD to the valves, the complicating factors according to the type of the VSD, and the size of the VSD with this concern. Okay, we will now go for the hemodynamic about the VSD, the estimation of the right ventricular systolic pressure and magnitude of the shunt. I will go briefly according to the pathophysiology of the VSD. So now we have a fixed amount of the blood. So what goes from the left ventricle, from the left atrium to the left ventricle should go to the aorta. and aorta give to the body, and superior vena cava, inferior vena cava return the same amount of the blood to the right atrium, then the right ventricle, then the pulmonary. So in absence of VSD, what goes outside the aorta should be equally to what goes outside the pulmonary. So if we divide the pulmonary flow to the aortic flow, it will end by 1. And the stroke volume of the RV is equal to the stroke volume of the LV. Exactly. Now we have a shunt of a VSD. That extra amount by yellow, like an extra amount, a amount that it will go from the left ventricle to the right ventricle in systole, not in diastole, because the pressure between the LV and the RV will be significantly high in systole, but almost at the same during diastole. If we now follow the extra amount of the blood from this VSD, so this amount will be ejected from the LV during systole to the contracted RV, so it will be not affecting the RV, it will be pushed to the pulmonary artery. So now we will have an extra amount of the blood, that X plus A in the pulmonary artery. It goes to the lung will be over flooded for a while, and it will come back from the lung pulmonary veins like an extra amount in the left atrium, extra amount in the left ventricle during diastole, then systole will be ejected to the pulmonary, so the aorta will receive the same amount. Now, if you look for that, the pulmonary have an extra amount of blood as equal as to the magnitude of the shunt, and the aorta have the same amount of the blood. If you divided the pulmonary flow by the aortic flow in a case of VSD, it will be more than 1. Okay. Which ventricle will be dilated in a case of VSD? The left ventricle or the right ventricle? Left ventricle will be dilated in case of VSD. The lung will be plethoric or not? The lung is flooded by the flow. Right? So, if we have a hemodynamic significant VSD, it will increase the volume of the LV, it will increase the stroke volume of the LV, and will increase the flow of the pulmonary. But what is the cutoff point? The cutoff point is if the pulmonary flow is 1.5, so it's increased by 1.5 amount than systemic circulation. So this is a significant shunt because the pulmonary flow is increased by the magnitude of the shunt more than the aorta. LV volume, we use the Z score. So if it's more than the 2-fold of the mean, so we consider that a dilatation of the LV. And because the lung will be flooded for a while, then the physiological process for this over-flooded lung to start to vasoconstrict for that. So if the RV pressure become more than 2/3 of LV pressure, how can I know the LV pressure? It's the systemic pressure. It's that you measure it from the RV. So if the RV pressure is more than 2/3 of the LV pressure, I consider that shunt as hemodynamic significant shunt. So I have to look for that, the magnitude of the shunt and the pressure of the RV. Is that clear now? So if the RV pressure is 1/3 of the LV pressure, so it's not significant. If the QPQS is 1.2, so if the LV volume is not dilated, so this is in hemodynamic significance. Okay.
LV pressure ده هيبقى لمين؟
لا, LV pressure is the systolic pressure that you measure by routinely from the arm. So the LV pressure is in adult is 120, 110. So we will go through that. Okay.
طب والار في اللي هو هحسبه من
We will go through that now. To measure the RV pressure in clinical practice, we do it echo. The most accurate way to do it invasively, that we go for the cath lab and just put hemodynamic catheter and measure the pump. But this is not the routine. This is in doubtful cases that we ask for the pressures. But in the daily scenarios, we just go for the echo. So what we will do by echo, we measure the gradient across the VSD. Okay? And we have the LV pressure from measuring the pressure of the patient from the systolic pressure. And if we subtract the pressure gradient across the VSD from the LV, we have the RV systolic pressure, right? And you remember in the first lecture about the ASD, if you have a tricuspid incompetence, so actually the tricuspid incompetence will give you the RV pressure, because this is the difference between two chambers. If you add the right atrium pressure on top of that, you have a systolic pressure. And if you measure the pulmonary incompetence, you have the mean pulmonary artery pressure. So both of them are talking about the systolic pressure, and which have to be more than what? 2/3 of the LV pressure to consider that significant. And the last one gives you an idea about the mean. So now you understand why your report have to include that. The pressure gradient across the VSD. We ask you if there is tricuspid incompetence, you have to measure it, and if there is pulmonary incompetence. In the case of VSD, your echo report have to have these 3 items. Now we will go through them. This is a VSD jet, and it is 4 meter by Bernoulli equation. The devices now do it for us. It's 60. If I told you that this pressure in this visit for the patient is 120, the pressure gradient is 60, this means that the RV pressure is 60. It's equal to more than 2/3 of the LV pressure? It's only the half. So this is not hemodynamic significant VSD according to the systolic pressure. Here the tricuspid incompetence. We have here tricuspid incompetence that we have it here is 70, is 4.2. So the tricuspid incompetence is 70. So the RV systolic pressure equal for what? For 70 plus the RA pressure, which is between 5 and 10. So it will be 75. If you compare it by the systolic pressure, which is 120, is 2/3. So this VSD is hemodynamic significant. Okay. For the mean pulmonary artery pressure, we just measure the pulmonary incompetence and we take the maximum. So here, so the mean pulmonary artery is around 18, which is acceptable. If it's less than 20, this mean pulmonary artery pressure is acceptable.
So can I ask a question?
Yeah.
Previous slide.
Yeah. This one.
No. It's a tricuspid regurg.
Yeah.
So in RV systolic pressure, tricuspid.
No, this is the same one. This is the same one. I wrote it here. Just I duplicated here. So the tricuspid regurg, this is misread. So the tricuspid regurg plus the right atrial. So it will be around 57 to 80. So the RV systolic pressure is 75 to 85. This is more than or less than 2/3.
More than.
It's more than 2/3. So here now you understand why your echo reports have to conclude, and you look actively for the pressure gradient across the VSD. You look for the tricuspid incompetence. You look for pulmonary incompetence, and you have to measure the blood pressure of your patient in each visit. Because if your patient is hypotensive and his blood pressure is 90 in a visit, and if this patient is hypertensive and his blood pressure is 150 in another visit, so you have to record. It's normal practice in Aswan that we wrote in our patient that the blood pressure during this exam is equal for that. If the patient is immediately post-operative and is vasodilated and the blood pressure is really low, you have to compare it by the systolic pressure. So this is a clinical point. In each VSD, you have to look actively for the tricuspid incompetence you say there is no tricuspid incompetence, so I didn't measure it. So there is no tricuspid incompetence, pressure gradient across the VSD. Both of them will give you what? Systolic pressure, and the pulmonary incompetence will give you mean pulmonary, which should be around 25. So this is the normal, and you have to measure the blood pressure in this visit population. Okay. Now we finished the RV pressures, and now we understand why in each report we had to measure that. Measure the systolic pressure in the visit. We have to measure the tricuspid incompetence, and if there is no tricuspid incompetence, we say no tricuspid incompetence and pressure gradient across the VSD and the pulmonary incompetence. Amr.
If we have discrepancy in between the
Take the mean. Take the mean. So usually there shouldn't be more than 5 to 10 difference between both of them, tricuspid incompetence and pressure gradient usually. So it shouldn't be unless you have a pulmonary stenosis, but usually it will be the same measurements, more or less. Okay, now we finish the RV pressure, and now we will talk about the magnitude of the shunt. So we have an internal agreement that the shunt should be more than 1.5 for the pulmonary to consider that is hemodynamic significant shunt. There is an indirect shunt qualification and direct shunt evaluation. In indirect shunt evaluation, this means that more blood go for the pulmonary artery, so the lung will be plethoric and flooded lung, and it will come back again from the pulmonary vein. So we look for the X-ray. First, if you have a plethoric lung, this means that this patient have a high pulmonary blood flow. And when the blood comes from the pulmonary veins to the left atrium, it goes from the left ventricle and stays in the left ventricle for diastole. And which ventricle will be dilated, the left ventricle or the right ventricle? Left ventricle. So in the echo measurements for the left ventricle dimension, by the echo, we measure the end diastole and the end systole, and we look carefully for the end diastole. If it's more than the accepted, the Z-score for this patient by 2 double, more than the Z-score by 2 double, we consider this dilated left ventricle. And in the children, we have to use the Z-score for them. So by echo and by X-ray, we have indirect evaluation for this shunt. And usually, this is enough. So if I have a child that is congested, chest infection, X-ray is plethoric, and left ventricle is dilated, and the pulmonary artery pressure give that RV systolic pressure is high, this hemodynamic significant, and usually in the clinical practice we stop at that point. Some cases are not straightforward. Some cases are in the grayish zone, so we are not sure about is it significant. It's not always white and black. But sometimes we have grayish area that we have to measure the flow. We have to measure the QP/QS. Old but still good by cath. So it was for long time the only way to measure the QP/QS in that patient. I know that a bit difficult, but this really a clever idea that in the body we have two circulation, the pulmonary circulation and systemic circulation. Thanks God we don't have a third circulation. So actually we can trace, and this circulation goes in parallel or in series? In series. In normal condition that it goes in series like what we saw in the drawing. So actually it goes from systemic circulation to the pulmonary circulation, and from pulmonary circulation to systemic circulation. So what think about it? If we can find a material that is traceable in this circulation, in the start of the circulation and at the end of the circulation, and we can measure the consumption of this traceable material between the beginning and the end of this circulation. So if you have from this traceable material, you have 100 at the beginning of circulation, and at the end of the circulation is 60. So the difference between the beginning and the end is 40. And you have a regular consumption in these two circulation. For that, you can trace the flow in between of them. So actually, think about what is exchangeable between both circulation is the oxygen. So actually, he traced the oxygen concentration in the beginning and the end of each circulation, and he assumed that consumption will be in the same patient will be fixed. So here comes the idea of this traceable material. So what is the beginning of the pulmonary circulation? What is the beginning of pulmonary circulation? It begins with the pulmonary artery. It ended by the pulmonary veins. It's easy. So the blood is going through the pulmonary artery, comes back in the pulmonary veins. And in systemic circulation, it started by aorta, it ended in the cava, in systemic veins, the inferior and superior vena cava. So he said, if you have the consumption concentration divided by the difference between the oxygen saturation in both in the beginning and the end of the circulation, this is the QP, and you have an oxygen consumption constant and the difference between the beginning and the end of the circulation in the systemic, so you have QB/QS. Now comes the tricky part, that we correlate the QP to the QS. We have here the numerator and denominator. So in this way, oxygen consumption divided by pulmonary, and because it is divided by, so now we have the difference between the systemic circulation and the oxygen consumption. We assume that both of them are the same constant. It ended up that QP/QS, we started by the systemic difference in the oxygen saturation divided by the pulmonary. Is that now clear why it's a QP/QS? We don't have that in the denominator, and this is in the denominator. Okay. And it's the daily practice in the cath lab that they go for each chamber of water of that and take a sample of the blood and measure the oxygen saturation in that. So in case 1, I put it here, how we calculate the QP/QS. So we have here the aorta is 80, inferior vena cava is 60, pulmonary vein is 100, and pulmonary artery is 80. So now the aortic saturation is 80 minus 60 is
20.
And here the pulmonary vein is 100 minus 80, so it is 20 by 20, so the QP/QS is 1, is balanced, VZ. Another one, we have the aorta is 90 and the inferior vena cava is 60, so the difference is 30, and we have pulmonary venous saturation is 100 and the pulmonary artery is 90, so it's 30 divided by 10, QP/QS is 3. This is how it goes in the cath lab. Is it clear? Okay, it has some limitation, but it's not the scope of this lecture. But this is how we calculated that in the cath lab. We measure the oxygen saturation in the beginning and the end of each circulation. So we have aorta minus cava, and we have the pulmonary veins or left atrium minus pulmonary. Okay. It's coming now in the current routine practice to have an MRI for that. Again, to calculate the actual shunt is not the daily practice. We keep it for the cases that we have a question mark on it. But usually, in direct method, X-ray, echo is more than enough. In addition, all what we have seen. Okay, MRI can give us two things: volumes of the ventricles, which one we expected to be dilated in a case of hemodynamic significant VSD, left ventricle, yeah, and it measured the flow in the aorta and in pulmonary. How it measured it? It might be a separate lecture. Now we have, this is what MRI gave us. They will tell us that left ventricular stroke volume is 170 and right ventricular stroke volume is 100. Which ventricle is overloaded? LV. and they said that aorta is 100 and pulmonary artery is 160. If we divided the pulmonary artery 160 over 100, it will give QPQS of 1.6. Is this significant or not significant? It's significant. And we have here that left ventricular stroke volume is more than it, so its left ventricular stroke volume is overloaded. This is how MRI people calculate things in that. Okay. Is it clear now? We have 6 points to check as a checklist in doing an echo for a child. For anatomy, exact anatomical location, and relation to the AV valves and the attached valves and complicating factors, size. And in hemodynamic,
significant or not?
yes.
RVSP.
RVSP, how to measure it?
Through tricuspid regurg, I will enchant sometimes
Pressure gradient across the VSD
I will mean pulmonary artery.
or mean pulmonary artery. So we have in each visit we have to measure, or I have to report the tricuspid incompetence, systemic blood pressure during that, pressure gradient across the VSD, and the mean pulmonary artery pressure. About the shunt, X-ray in each visit and measurements of the LV, it's enough as indirect method. If you have a doubt about do the CMR or do the castration. Nowadays, in simple lesion like a VSD, MRI is more than enough if the question about the QBQS. Okay, I'm almost done about the VSD, but there is some tricky points about the VSD. First, as we said, the VSD is the most common congenital heart disease, so it's not infrequent that you have a baby of 10 days. They did a screen by echo for any reason, and they find mid-muscular VSD. What you will say? Why? And for example, you didn't ask about hemodynamic significant or not. We have a mid-muscular VSD, so it is the exact location is mid-muscular. It's not related to the any valves, not related to the AV valves and the aorta. So the aortic valve is okay and pulmonary valve is okay, and the size is 5 millimeter. You have to check everything right there. It's not complicating by any factor. It's just a single VSD. And for hemodynamic, for example, that pressure gradient across this VSD is 10, and the systolic blood pressure is 90.
Okay, its RV pressure is
10 days. Okay, you have to do the checklist, right? We did the checklist, and
I will measure blood pressure of this baby. It's around
90.
90. Okay, but the pressure gradient
It's 10.
10. The RV pressure is high.
Exactly.
Okay, but it's the first 10 days there is a pulmonary vascular stain.
Exactly. This is one of the trickiest point in that. So actually the hemodynamic of the VSD depends mainly on the variant of DVR. So exactly as you pick it up, this baby is not in his equilibrium yet. So in the first 6 weeks of age, maybe 2 months, so we still have the neonatal, the normal physiological increase in pulmonary vascular resistance. So actually, this does not represent the hemodynamic significance of the VSD. This represents that we still have equal in the blood pressure in both of them because the RVSP is high, not because of the complication of this VSD, but this is normal. So actually, this is normal daily practice for any doctor, that you have a neonate with a VSD and you ask whether correctly said that we followed this baby up and we do the other echo, not the next week or after 3 weeks. We do it after 2 months of life. So now there is a drop in the BVR, but this physiological increase of the BVR. So never give a strong opinion in the neonates who have a VSD. You have to follow it up. Okay. Okay. Which type of VSD that we have here?
We cannot judge.
Yeah, it is either it's subarterial or premembranous VSD. So actually we have a prolapse of one cause. It's competent, and when we did the TE, actually this was a lady which followed up who have a premembranous VSD and after labor, and we found that this is a TE, and we found here a mass in the RVUT attached to the aorta. Is it clear? This lady presented after labor by a week, feverish, and then septic condition and toxic low. And we have here, you look for this. We have here vegetation attached to that. So actually, this is a bit tricky point because the guidelines in 2010 they advise against infective endocarditis prophylaxis in left to right shunt. Actually, they keep the infective endocarditis prophylaxis for 4 categories. If the patient have infective endocarditis before, if it's cyanotic, if there is a residual defect after repair or use synthetic material, none of them are the VSD, but they wrote in a small letter that each country have to judge for itself about that, this updated recommendation. So we still, in our countries, we do recommend to give infective endocarditis even if this not hemodynamic VSD, and we will go not to close it. So we recommend to give infective endocarditis, especially if there will be any intervention like dental procedure or labor. So although the guidelines, but this is the European guidelines, does not recommend for infective endocarditis prophylaxis, but we do recommend for that. Okay. This is what we said about how to do that. The third point, the pulmonary artery banding might have a role in the VSD. You remember about the inlet VSD with the straddling? So actually, if this is a hemodynamic significant VSD and we have to close it to keep the pulmonary vascular resistance low and does not go for, what will happen if we does not close this VSD and we let the pulmonary artery pressure to go to the maximum? With Eisenmenger. This is an Eisenmenger, might be one of the next lectures that we will talk about the reversed left to right shunt, right to left shunt. But if you are not able to close this VSD, like the straddling, which VSD that we said we are not able to close? So the muscular, as we said, that the muscular VSDs have a tendency to come in clusters or in groups. So if you are not able to septate a heart, we have to protect the lung. So pulmonary artery banding comes as an option to protect the lung if you are not able to close the VSD. So pulmonary artery band is not curative treatment for the VSD, but it might help a lot if it's difficult, if it's the baby is small, if it's in high risk VSD, you do pulmonary artery banding. So this is three tricky points about the neonatal VSDs. Never give an opinion about its hemodynamic significant or not before the age of 6 weeks, 8 weeks is okay. And infective endocarditis, we still do recommend in our countries to go for infective endocarditis prophylaxis regimen, even in non-significant VSD. Pulmonary artery band is an option if you are not able to close this VSD for any reason. I'm done with the VSD lecture. Any questions?
No, thank you.
Yeah.